You've been doing everything right. You cut back on the bread. You're walking every morning. You're watching your portions. But every time you step on that scale, the number goes up. Or maybe it doesn't go up, but you've noticed something strange. Your clothes feel tighter. Your belly is bigger. You feel heavier in a way that just doesn't match how you've been living. Here's what most people never consider. The answer might not be what you're putting in your mouth at the dinner table. It might be what you're putting in your mouth from that little orange bottle on your nightstand. I'm Dr. William Lee, and today on Aging Strong Together, we are talking about 5 common medications that can cause you to gain up to 30 pounds, sometimes more, especially if you're over 60. Now, I want to be crystal clear before we go any further. I am not telling you to stop taking your medications. Absolutely not. Some of these drugs are genuinely life-saving. What I am going to do today is give you the knowledge to have a smarter, more informed conversation with your doctor. Because here's the thing, your doctor might not have mentioned this side effect, not because they don't care about you, but because when you're managing a serious condition, weight gain can feel like a secondary concern. Today we're going to make it a priority. Stay with me through all 5 because number 3 is the one that shocks almost everyone. It's hiding in plain sight and millions of Americans over 60 are taking it right now. Let's get into it. Before we name the 5 medications, I need to spend just 2 minutes explaining why this is especially important for people in their 60s, 70s, and beyond. When you were 35, your body had a remarkable ability to compensate. Your metabolism was faster, your hormones were more balanced, your liver processed drugs more efficiently. That is not the world we live in after 60. After 60, your resting metabolism has slowed significantly. Your muscle mass has decreased, and muscle is your body's #1 calorie-burning engine. Your hormones have shifted, and your kidneys and liver, the organs responsible for processing and eliminating medications, are simply not working at the same speed they once were. What this means is the same medication that had minimal side effects at 45 can hit your body very differently at 65. There's also something called polyarm pharmacy, and this is a real problem for older Americans. The average person over 65 is taking somewhere between 5 and 9 prescription medications every single day. These drugs interact with each other. They compound each other's side effects. And weight gain is one of the most common and most overlooked consequences. And before anyone dismisses this as a cosmetic issue, let me be very direct. Unexplained weight gain after 60 is a serious medical concern. It increases your risk of type 2 diabetes. It puts extra pressure on arthritic joints. It raises blood pressure and strains your heart. It disrupts sleep. And the research is very clear. Excess abdominal fat in older adults is associated with significantly higher rates of cardiovascular disease. This matters. Your weight matters, and the medication in your cabinet may be working against you. Our first medication is one of the most commonly prescribed drugs in the entire United States, corticosteroids. You might know it by the brand name prednisone or prednisolone or methylprednisolone. These are anti-inflammatory steroid medications, and they are prescribed for a very wide range of conditions that are extremely common in adults over 60. Rheumatoid arthritis, COPD, lupus, inflammatory bowel disease, skin conditions, asthma flare-ups, even allergic reactions. If you've ever been handed a steroid pack after a bad flare-up, you've taken a corticosteroid. Now here is what these drugs do inside your body that has nothing to do with why your doctor prescribed them. Corticosteroids dramatically increase your cortisol levels. Cortisol is your primary stress hormone, and in high amounts sustained over time, it tells your body to do something very specific. Store fat, especially in the abdomen, the belly, the face, the back of the neck. A classic sign called buffalo hump. Long-term users also frequently experience what's called moon face, where the cheeks become noticeably fuller. On top of that, corticosteroids cause your kidneys to retain sodium, which means your body holds on to water and they directly stimulate your appetite. They make you hungry, not just a little hungry, profoundly, persistently hungry. When you combine increased fat storage, water retention, and a dramatically increased appetite, the results are significant. Studies show that patients on long-term corticosteroid therapy can gain 20 to 30 pounds or more, and a substantial portion of that weight accumulates right around the midsection. So what do you do if you're on a corticosteroid? First, talk to your doctor. Ask, am I on the lowest effective dose? Is there a way to step down? Short-term or intermittent use is far less problematic than daily long-term use. Second, ask about alternative delivery methods. For respiratory conditions, inhaled steroids deliver medication directly to the lungs with far less systemic absorption, meaning far less impact on your weight. Third, for conditions like rheumatoid arthritis, ask whether biologic medications might be a better fit. Biologics target specific pathways in the immune system without the same whole-body hormonal disruption. You may not be able to come off steroids completely, but even a small reduction in dose or a change in how the medication is delivered can make a meaningful difference on the scale. This one is particularly frustrating because it's a cruel irony. Diabetes is a condition deeply tied to body weight. Excess weight is one of the primary drivers of type 2 diabetes, and yet some of the oldest and most widely used diabetes medications actually cause weight gain. Let's talk about two categories. First, insulin. When you inject insulin, whether it's long-acting or rapid-acting, you are introducing a hormone whose job is to move sugar out of your bloodstream and into your cells, your muscle cells, your liver, and critically your fat cells. Insulin is a storage hormone. It tells your body to hold on to energy. In people who take insulin, especially at doses that occasionally result in mild low blood sugar episodes, you're also triggered to eat more to correct those lows. The result? Many insulin users gain 10 to 20 pounds in the first year alone. Second, sulfonylureas. These are older oral diabetes drugs with names like glyphoside, glyuride, and glypiride. They work by forcing your pancreas to produce more insulin. Whether you need it or not, same mechanism, similar outcome. Weight gain of 5 to 10 pounds is extremely common. Now here's where the good news comes in, and this is genuinely exciting. In recent years, there are entirely new classes of diabetes medications that don't just avoid causing weight gain, they can actually help you lose weight. SGLT2 inhibitors like Jardiance and Farxiga work by making your kidneys excrete excess sugar in your urine. They commonly result in 5 to 10 pounds of weight loss and also have strong cardiovascular and kidney protective benefits. GLP-1 agonist. You've probably heard of this class because of the enormous attention drugs like Ozempic and Trulicity have received. Promote weight loss, improve blood sugar control, and have strong heart protective effects. Metformin, the oldest and still most widely prescribed diabetes drug, is generally weight neutral or even associated with modest weight loss. If you're on insulin or sulfonylureas and you're concerned about weight gain, ask your doctor, given my current health, would I be a candidate for newer medications that are weight neutral or weight friendly? This is one of the most impactful conversations you can have. Here it is, the one I promised you, the one that almost nobody suspects, antidepressants. And I want to acknowledge something important before I go further. Depression is real. It is serious. It is widespread in adults over 60, particularly those who are managing chronic illness, loss, isolation, or major life transitions. Antidepressants save lives, and I am not minimizing that for a single moment. But you deserve to know what some of these medications can do to your body over time. And the data here is significant. Certain SSRIs, selective serotonin reuptake inhibitors, are among the most widely prescribed medications in America. Drugs like paroxetine, brand name Paxil, and to a lesser extent sertraline, Zoloft, have been consistently associated with weight gain, particularly with long-term use. The mechanism is complex, but here's the simplified version. Serotonin plays a role in appetite regulation and impulse control. When you artificially elevate serotonin over a long period of time, some people experience increased cravings, particularly for carbohydrates and sweets. Your brain starts wanting those quick hits of glucose in a way it didn't before. But the medication I want to focus on specifically is mirtazapine, brand name Remeron. Mirtazapine is prescribed for depression, anxiety, and sometimes for insomnia or appetite stimulation in older patients who have lost weight due to illness. And it does that job very effectively, almost too effectively. It works partly by blocking histamine receptors, which is the same mechanism that makes antihistamines like Benadryl cause drowsiness and increased appetite. In clinical practice, I have seen patients on mirtazapine gain 15 to 30 pounds within 6 to 12 months. That is not an exaggeration. It is a well-documented side effect. What are your alternatives? Bupropion, brand name Wellbutrin, is an antidepressant with a completely different mechanism of action, and it is the only antidepressant consistently associated with modest weight loss rather than weight gain for appropriate patients. This can be a game changer. SNR is like duloxetine Cymbalta, tend to be more weight neutral than SSR is, and have the added benefit of treating chronic pain, which is an extremely common comorbidity in adults over 60. Cognitive behavioral therapy, CBT, has been shown in multiple studies to be as effective as medication for mild to moderate depression, with obviously zero metabolic side effects. Please do not stop taking your antidepressants suddenly without medical supervision. Discontinuation syndrome is real and can be severe. But have the conversation. Ask, is there an alternative that might be easier on my weight? Could we review my dose? You deserve to feel mentally well and physically strong. Both matter. If you're over 60 and you have high blood pressure, heart disease, or a history of heart attack, there is a very good chance you are on a beta blocker. Amitriptyline, Atenol, propranolol, carvedilol. These drugs are workhorses of cardiovascular medicine, and for many patients they are absolutely essential. But here is something your cardiologist may not have brought up at your last appointment. SNORTs. Beta blockers are significantly associated with weight gain, and they work through a mechanism that is particularly insidious for older adults. Beta SNORTs blockers slow your heart rate, that's their job, but slowing your heart rate also slows your metabolic rate. Your body burns fewer calories at rest. The effect isn't dramatic. We're talking perhaps a 5 to 8% reduction in resting metabolism, but compounded over months and years, it adds up. There's a second mechanism as well, fatigue. Beta blockers commonly cause a feeling of tiredness, low energy, and reduced exercise tolerance. When every walk feels harder, when climbing stairs leaves you more winded than it used to, you naturally move less, and moving less means burning fewer calories. The combination slower metabolism plus reduced activity accounts for an average weight gain of 5 to 15 pounds in long-term beta blocker users. What can you do? The conversation to have with your cardiologist is about newer generation beta blockers. Carvedilol and nebivolol are third-generation beta blockers that work through slightly different mechanisms and have a markedly better metabolic profile. Studies suggest NBVOL in particular has significantly less impact on weight and metabolic rate than older drugs like Atenol. You might also ask whether you still need a beta blocker at all. Guidelines have evolved. If you've been on a beta blocker for years following a cardiovascular event, It may be worth asking your doctor whether a different class of medication, an ACE inhibitor or an ARB, might now be appropriate for your current health status. Again, do not make this change unilaterally, but do ask the question. Our fifth and final medication is one that has seen absolutely explosive growth in prescriptions over the past decade, particularly in older adults. Gabapentin, brand name, and its close cousin pregabalin, brand name Lyta. These snorts drugs were originally developed as anti-seizure medications, but today they are prescribed primarily for nerve pain, diabetic neuropathy, post-eretic neuralgia, the pain that follows shingles, fibromyalgia, sciatica, and general chronic back pain. If you've had nerve pain, that burning, shooting electric shock sensation, you know how debilitating it can be, and these drugs can genuinely help. I want to acknowledge that. But the weight gain associated with gabapentin and pregabalin is substantial and underappreciated. Gabapentin works by calming overactive nerve signals in the brain. One of the byproducts of that calming effect is that it directly increases appetite, particularly cravings for calorie-dense foods. It also causes significant fluid retention, water weight that can be surprisingly dramatic. And then there's the fatigue and sedation. Gabapentin is known for making people feel foggy, sleepy, and physically lethargic. For older adults, this is not just a minor annoyance. It directly translates to less daily movement, less intentional exercise, and fewer calories burned. On long-term gabapentin, patients commonly gain 10 to 20 pounds, and many are completely unaware that the drug is responsible because the weight gain happens gradually over months. What are the alternatives? Duloxetine Cymbalta is FDA approved for several pain conditions and tends to be weight neutral or even associated with modest weight loss. For neuropathic pain specifically, it can be an effective substitute. Topical treatments, lidocaine patches, caps and cream deliver pain relief directly to the affected area without systemic side effects. Physical therapy and targeted exercise have shown strong evidence for chronic back pain and can, for appropriate patients, reduce the need for medication altogether. If you are taking gabapentin for chronic pain, ask your doctor, are there non-cystic options or alternatives that might have less impact on my weight and energy levels? Alright, we've covered 5 medications, and I want to make sure you don't leave here feeling overwhelmed or helpless, because you are absolutely not. Knowledge is power, and what you now have is the knowledge to advocate for yourself. Here's your 3-step action plan. Write this down. Step 1, list it. Before your next doctor's appointment, whether that's tomorrow or 3 months from now, sit down and write out every single medication you are currently taking. Prescriptions, over-the-counter drugs, supplements, everything. Then, next to each one, write down the date you started taking it and write down what your weight was roughly around that same time. This is data, and data changes conversations. Step 2, ask it. When you sit down with your doctor, say these words: I've been reading about medication-related weight gain, and I want to understand, could any of the medications I'm currently taking be contributing to my weight? And if so, are there alternatives that might be easier on my metabolism? That's it. That's the question. Write it on a piece of paper and bring it with you if you need to. A good doctor will take that question seriously. If yours dismisses it without any discussion, that's information too. Step 3, track it. Going forward, weigh yourself once a week at the same time of day on the same scale. And whenever your doctor adds a new medication, changes a dose, or removes something, note it in the same log. If you start gaining weight within weeks of a medication change, you now have the documentation to bring that conversation back to your doctor. 3 steps: list it, ask it, track it. Let's do a quick recap of our 5 medications. Number 1, corticosteroids like prednisone up to 30 pounds through cortisol-driven fat storage and appetite increases. Number 2, older diabetes medications. Insulin and sulfonylureas 10 to 20 pounds, with far better alternatives now available. Number 3, certain antidepressants, particularly mortazepine, 15 to 30 pounds through appetite stimulation and metabolic changes. Number 4, beta blockers 5 to 15 pounds, by slowing your metabolism and reducing your exercise tolerance. Number 5, gabapentin and pregabalin, 10 to 20 pounds, through appetite increases, fluid retention, and fatigue-driven inactivity. Now, I want to leave you with this. You have worked hard to get to this point in your life. You've managed health challenges, you've adapted, you've shown up every single day. You deserve a medical team that sees your whole picture. And that includes understanding how the medications meant to help you might also be working against you. You are not helpless in this. You are your own best advocate. And that conversation, the one I just gave you the words for, could genuinely change your trajectory. If you found this video helpful, please hit that like button right now. It truly helps more people find this information who need it. And if you're not subscribed to Aging Strong Together yet, subscribe and ring that bell, because every week we are bringing you real practical doctor-backed information for living your strongest life after 60. And one more thing, I'd love to hear from you. Leave a comment below. Which of these 5 medications were you most surprised by? Let me know. I read every comment. I'm Dr. William Lee. Take care of yourself, and I'll see you in the next